Hi everyone, Dr. Robin Chatkan here. Welcome to today's office hours on antibiotics and the risk of autoimmune diseases. I'm going to give everyone a minute to join, but I'm really excited to have you with me today for this really important topic. And this is something that I see over and over again in my medical practice is people who've been on antibiotics and then develop autoimmune diseases. So welcome. Hi everyone. It's always such a pleasure to join you on Tuesdays. And while you're joining, I'm going to just give a little brief intro about this topic and why it's so important. So what we're going to be talking about today is the risk of antibiotics and autoimmune diseases. And to understand that risk, I'm going to go back a little bit in time and talk about the hygiene hypothesis. Some of you who've joined me for these talks before or are just well informed will know all about the hygiene hypothesis. But for some of you, it may be a new topic, and it's really sort of foundational for understanding autoimmune diseases. And then when you understand the hygiene hypothesis, you can then understand how additional assaults on our microbiome through antibiotics can result in a perfect storm of autoimmune disease. So welcome. Thank you so much for joining me. Again, I'm Dr. Robin Chatkan. And today I'm going to be talking about antibiotics and the risk of autoimmune disease. Let me just remind you, I know you know this, but let me remind you that what I'm discussing today is not medical advice. I'm not giving you medical advice. This is just for educational purposes. And it's a really fascinating topic and one that's becoming more and more important as we look at autoimmune diseases. So let's start off with a definition. What is an autoimmune disease? An autoimmune disease is a defect in immune tolerance. And what that means is that our body responds to things that it shouldn't normally respond to with an immune reaction. So immune tolerance means that our immune system is well trained and well informed and is able to distinguish friend from foe. So I'll give you an example. In the GI tract, we have trillions of organisms floating around inside our gut. And the immune system, which is just on the other side of that gut lining. So remember, you have the gut lining, one cell thick, razor thin, and on sort of the inside, meaning inside the body, you have all the immune processes going on. And on the outside of that lining, meaning in our gut, because things in our gut are not actually inside our body. They're in this hollow tunnel that runs the length of our body. So the inside, we have all the trillions of bacteria. And in addition to those microbes that are helpful, we also have things that are not so helpful. We have, maybe SARS-CoV-2 that we swallowed. We have toxins, etc. So we have pathogens, infectious organisms, we have toxins, we have poorly digested food particles. And our immune system has to understand, particularly when we're talking about pathogens, what to respond to and what to ignore. And of course, it's a gut bacteria that help to modulate and guide that process, that literally say, okay, this is something really problematic and I want you to mount a big immune response. And this is a harmless pathogen, just ignore. So you need to have that training of your immune system. And a lot of that training comes from exposure to microbes, right? If we grow up in a super clean, super sanitized environment, which I'm going to talk about in a minute with the hygiene hypothesis, then we have a poorly trained immune system. And what happens with that poorly trained immune system is that there are, again, these defects in immune tolerance, meaning that our immune system is sort of trigger happy and responding to things that it shouldn't respond to, like our own normal tissues. So that's what happens when you have an autoimmune disease. In the case of Crohn's disease and ulcerative colitis, two gut-based autoimmune conditions that are my area of expertise, we see overreaction to the normal gut flora, and we see ulceration and strictures and severe inflammation in the gut as a result of the body essentially destroying its own gut tissue. In the case of rheumatoid arthritis, it's the joints. In the case of psoriasis, it's the skin, etc. So we have now over 100 different autoimmune diseases. And check this out, 1 in 4 Americans have an autoimmune disease, and many have more than one. I have 2. I have eczema and I have Raynaud's phenomena. So Raynaud's is something where your fingers can turn white or blue in the cold or with a change in temperature, and eczema, I think you know what that is. And so these are exceedingly common, over 50 million Americans. Chances are, if you don't have an autoimmune disease yourself, and hopefully if you do, it's something mild like what I have with the eczema and Raynaud's. But chances are, if you don't have an autoimmune disease, you know someone who has one, someone in your family a close friend, etc. And the reason why people often have more than one autoimmune disease is because the factors that cause autoimmune disease are common and they can lead to more than one autoimmune disease. So when we look at what these factors are, there is a genetic predisposition, yes. So for example, with Crohn's disease, Judy Chu at University of Chicago and colleagues discovered the Crohn's gene. It turns out there's several what we call susceptibility loci, NOD2 on chromosome 16, etc. So there are several different genes that are associated with Crohn's, but the genes alone are not enough to cause the disease. There's an environmental trigger. What is that environmental trigger? Well, it's lots of things. It can be infection, it's a poor diet, it can be medication, and it turns out that disruption to the microbiome is a significant environmental trigger. So we have a big study looking at onset of juvenile rheumatoid arthritis, JRA, an autoimmune disease, a form of rheumatoid arthritis, but the children get. And we see that antibiotic use can be a trigger. We know antibiotic use can be a trigger for Crohn's and ulcerative colitis in kids. We have that previous data from an article way back in 2014, almost 10 years ago, from the American Journal of Gastroenterology that showed that frequent antibiotic use was associated with an increased incidence. We have studies from Canada showing the same thing. So there's not really any debate about that. What prompted me to pick this for today's topic was an article that came out just a few days ago, a week or so ago. I think it came out on my birthday, actually, on January 11th. And this was a study, a population-based study from Denmark. So people in some European countries, Scandinavia, etc., are very good at these population-based studies. And they looked at over 6 million adults. And they asked the question, is there a higher incidence of inflammatory bowel disease, of Crohn's and ulcerative colitis in people after taking antibiotics versus people who have not been exposed? And this is primarily people with no family history, okay? And the answer was yes, and it was a resounding yes. So particularly in the over 40 age group. And so again, we already have the data in kids. And what's interesting here is inflammatory bowel disease is typically an autoimmune disease that affects people at a fairly young age. So if we look at Crohn's disease, somewhere between 80 and 90% of people are diagnosed before their third decade. They're diagnosed as teenagers and young adults. And some of that we think has to do with the hormonal changes and how that can affect the microbiome, right, after puberty. But we already have the data about antibiotics being a potential triggering event for inflammatory bowel disease in kids, and antibiotics increasing the risk significantly. That's a study I told you about from almost 10 years ago and multiple other studies. So that was not in question. What is interesting about this study is they showed the increased risk in adults, in people over 40. And here's the deal. The more antibiotics you took, the higher the risk, right? So the people who were at highest risk for developing inflammatory bowel disease were people who had taken 5 or more courses of antibiotics. All right, so again, it's really important. I want to say that again. It seems to be a cumulative effect. The people who were at highest risk for developing autoimmune diseases, particularly in this study, inflammatory bowel disease after antibiotics, were people who had taken 5 or more courses of antibiotics. And the risk was greatest 1 to 2 years after taking the antibiotics. And so I'll tell you, in my practice, I see 2 peaks of inflammatory bowel disease. I see the sort of conventional peak. People are diagnosed in their teens, early 20s. Many, but not all, have a family history of IBD, about 20 to 25%. But that means that the majority don't, right? And then I see a second peak in adulthood, somewhere in that sort of 40 to 60 age range. And it seems that that second peak is a type of inflammatory bowel disease. I mean, it's the same Crohn's and ulcerative colitis, but it is, when I say a type, it is often triggered by environmental factors like antibiotic use. And remember that as we age, our microbiome typically is becoming less diverse, right? It's sort of waning. And that lower diversity puts us at risk for these autoimmune diseases anyway. So if you add to that antibiotic use, significant antibiotic use, if you add to that a sort of crummy diet, right? High in animal fat and animal protein and sugar and low in fiber. If you add to that alcohol, if you add to that stress, if you add to that limited exposure to nature, that can all add up to a potent mix, a perfect storm that begets autoimmune disease. So I want you to remember, it's not any one thing. It's not, aha, my genes, I have a gene for this disease, I'm going to develop it. Very unusual. Very few diseases have just a straight up genetic impact like that. The genes are a suggestion. And you don't even need the genes, as we're seeing in the majority of people with inflammatory bowel disease don't have a family history. It's not a genetic disease. But again, it is this perfect storm of diet, environmental factors like stress, like exercise, like exposure to nature, and disruption to the microbiome through antibiotics. So that was a Danish study. They looked at over 6 million people. This was a big study. And the article is published in the journal Gut, and it was published just this January. The lead author is Adam Fay, F-A-Y-E, from NYU. And I did post a link in the comments in my post a day or two ago about where I did a little caption, a little post about this study and antibiotics increasing the risk of IBD. It was a day or two ago. So if you look down through the comments, you'll see the link to the study. So let's go back now and talk about the hygiene hypothesis, all right? I told you about the relationship between the microbiome and the autoimmune processes going on right across the gut lining and how important that interaction is. So David Strawn, he's now Sir David Strawn, who is an epidemiologist back in the 1950s at the London School of Tropical Medicine and Hygiene. I think he's somewhere else now, but that's where he was at the time. Did a really important study. He was tasked by the British government with figuring out why they were seeing high rates, skyrocketing rates, in fact, of autoimmune diseases in children. And two in particular, eczema and hay fever, which is essentially a form of asthma. And so he embarked on a 21-year-long study, 17,000 children from birth to adulthood, looking at what are the risk factors for developing these autoimmune diseases. And he found two really important things. And if you sort of, listen to what I write and say, you've heard me talk about the hygiene hypothesis. I talked about the study in my first book, Gut Bliss. I talked about it in my second book, The Microbiome Solution. I talked about it in my most recent book, The Antiviral Gut, because it is really, really important. It is foundational for understanding how many of these autoimmune diseases develop. So what did he find? He found that kids from families where they had a lot of siblings and they were getting sneezed on, coughed on, they were getting exposure to a lot of childhood illnesses, they had low rates of autoimmune disease. They were essentially sort of immunized, if you will. Their immune systems were exposed to a lot of germs growing up and were well trained, knew how to distinguish between friend and foe. They found that kids from more affluent households who back at the time in post-industrial London, doesn't apply today, but those kids were bathing more, they were cleaner, they were living in cleaner surroundings, and they had higher rates of autoimmune disease. So it flipped this idea of, that cleanliness is a good thing. When it comes to your immune system, being super sanitized and washing all the time and living in a sterile environment where you're not exposed to nature and there's no dirt around, there are no pets, turns out to not be such a good thing for your immune system. I mean, the data about pets is very clear. Kids who are exposed to dogs in particular, but cats too, where these animals are bringing in some of the environment, they're bringing in dirt and germs and so on, actually really good for kids. Those kids have fewer episodes of antibiotic use and lower rates of asthma and some other things. There was just an article about that, about kids with pets and lower rates of asthma and kids growing up on the farm. That study had to also do with milk, and then you have to talk about pasteurized versus unpasteurized, so I'm not going to digress. But David Strawn's important work formed the basis for what we now know as the hygiene hypothesis, and it was added to by Sir Graham Rooke, another researcher who was knighted in the UK for his important work. And Graham Rooke's work is called the Old Friends Hypothesis. And it says that it's not just exposure to relatively new viruses like influenza that's important for training the immune system. It's also exposure to old parasites and other sort of ancient illnesses that is really important for training the immune system. So I'm not going to get too much into that, but let's just say that exposure to germs, particularly in childhood, is a good thing. Now, there can be such a thing as too much of a good thing, right? You don't want, your children living in dirt all the time, for sure. But what's really interesting is if you look at a map of the world today, you still see high rates of autoimmune disease in more developed countries, in North America, in Western Europe, etc., in Australia. High rates of autoimmune diseases like Crohn's, ulcerative colitis, etc. Low rates in less developed countries where it's not just a McDonald's phenomenon, right? That we're eating ultra processed foods, etc. We have less exposure to nature in the more developed world compared to the less developed world. So we are, there's some good things that come with that, right? We have a safe water supply. We don't have to worry about getting cholera from the drinking water. We have access to lots of modern conveniences that keep us safe. But with that comes also a highly pesticized food chain and, chlorine in the water that, yes, it kills cholera, but it also kills a lot of the bacteria in our bodies when we drink it. So it's a bit of a double-edged sword. And for sure, as we see countries becoming more industrialized, we see higher rates of these autoimmune diseases developing. And a lot of that, too, is a use of antibiotics. So as countries become more industrialized, typically, remember, it's not just antibiotics a doctor is prescribing for you. It's also the antibiotics in food. 80% of the antibiotics in the US, this is an estimate, are used in the food industry for animal fattening. In the animal industry, they're given prophylactically to dairy cows who are always getting infections because they're udders, they're just constantly producing milk. So a lot of it, even if you are a good steward of antibiotics and you're, declining antibiotics that aren't completely necessary, or you just are healthy, depending on what you're eating, you may still be getting exposed to significant antibiotics, depending. So that is a hygiene hypothesis. And what's interesting is this research was done in the 50s, 60s, and 70s. The article was published in the 80s, that sort of landmark article. But we still see, when we see a map, look at a map of the world today, we still see that difference, right? And as countries become more industrialized, I tell this story all the time of one of my GI fellows from Saudi Arabia who didn't want to come to my IBD clinic, my inflammatory bowel disease clinic. Remember, IBD, Crohn's and ulcerative colitis, inflammatory bowel disease, completely different from IBS, irritable bowel syndrome. He didn't want to come to my IBD clinic when I was full-time at Georgetown because he said, we don't see this in Saudi Arabia. And fast forward, I saw him at a GI conference about a decade later, and he was like, oh yeah, now we have a whole IBD clinic at the hospital where I am because we're seeing such high rates. So we're seeing this in India, in the Middle East, even in the Caribbean where I'm from. We're seeing increasing rates of autoimmune diseases as we start to see more industrialization and more access to antibiotics. Okay, so let's be clear, right? Access to antibiotics can be a great thing. Access to healthcare can be a great thing, but we have to be more judicious stewards. What was really interesting in that Danish study is that they found, so the more antibiotics you took, the greater the risk, right? But it was also the antibiotics that we use for gut infections that had the greatest risk. So things like ciprofloxacin, the fluoroquinolones, and others, metronidazole. And most of these gut infections are self-limited. So when I look at the patients I see, living in Washington, D.C., I treat a lot of international patients. I treat a lot of people who work at the World Bank, the IMF, State Department, from embassies, or traveling a lot. And a typical situation will be, somebody was stationed somewhere. Let's just say they were in East Africa somewhere, and they got a bug. And they go to the State Department doctor and they give them lots of antibiotics because they're like, you have an infection. We don't know what this is. So typically they give them like Cipro, metronidazole, something like that. And maybe it clears up a little bit, but then they have a real change in bowel habits, and then they really start to have diarrhea, bloating, etc. And sometimes they develop just what we call post-infectious irritable bowel syndrome, but occasionally they'll develop inflammatory bowel disease. So the point I'm trying to make as a gastroenterologist who is very interested in the microbiome and in preserving microbes, I see a lot of these diseases developing not because of the original infectious organism, but because of the treatment with the antibiotics, and often excessive antibiotics, because they give them antibiotics, they don't get better, they give them more. So 5 or 6 courses of antibiotics later, now there's a different problem. And this is not an infectious problem. Now it's a dysbiotic problem with an imbalanced microbiome. It can be, not to sort of throw the Peace Corps State Department doctor onto the bus. it can be challenging, right? I mean, you're dealing with somebody who's living in a different environment, who is not used to all these different organisms, who sometimes doesn't even have an active infection, but they're colonized with new organisms. And as a result of that colonization, they're having symptoms. They're having gas, bloating, maybe diarrhea. And so it can be really tempting to go ahead and say, oh, I'm just going to give you an antibiotic, right? I have a really high threshold, as most of you probably gleaned, for antibiotics. And I think some of my patients joke, half jokingly, that, you know, if death is imminent, she's good with you taking an antibiotic. That's an exaggeration, but I'm always recommending to people, like, if you are not sick, if you don't have severe abdominal pain, if you don't have a fever, if you don't have significant abdominal tenderness, if you're not, you know, having severe vomiting, because here's the thing, for a lot of these gut-associated infections, the antibiotics can actually prolong the carrier state. They can make the period of time for which you're infectious longer, and make it so that your recovery really isn't faster at all, and you are infectious for longer. So watchful waiting, you know, you always want to make sure we pay attention to people's hydration status and make sure that somebody's not getting dehydrated and that they can tolerate fluids and so on. We want to make sure there's no signs of a more severe systemic infection, like E. coli 0157H7 subtype is a foodborne illness, and it can cause a severe gastroenteritis and something called hemolytic uremic syndrome, HUS, that can affect the kidneys, and very, very significant illness. So you have to really, in your triage, you know, be familiar and be able to decide, okay, is this self-limited, and does this person just need support with fluids and so on and things to make them more comfortable, or do they actually need an antibiotic? And we have to move away from this knee-jerk, you know, anything that's wrong with you, you have a little sniffle, you have a little diarrhea, here's an antibiotic, because there is no question whatsoever, no doubt, and this isn't my opinion, this is scientific fact, that these antibiotics are potentially ruinous to our microbiome and are predisposing us to an autoimmune disease. And it's not just those of us with a family history of autoimmune diseases, even in the absence of a family history. And these, you know, these effects are cumulative. So if you grew up in a very urban environment with minimal exposure to rurality, to trees and animals, etc., if you have eaten a diet that's high in sugar and animal protein and fat and low in fiber, if you have been drinking a lot of alcohol, if you have been under a lot of stress, if you have taken acid blocking drugs that affect your GI tract, like all of these things are cumulative, and there's more things too, right? These are some of the sort of classic ones. So a lot of what I do, you know, it's interesting when people come to see me, sometimes they're sort of interested in, okay, you know, we want you to pull out the magic wand and like, what's the magic probiotic combination that's gonna heal us? And so often the answer is about what I want you to stop as opposed to what I want you to take. It's really educating people so that they can understand the risk of some of these medications that, and again, while they can be life-saving, right? The discovery of penicillin, now, gosh, almost a century ago, is by Dr. Fleming, is one of the greatest discoveries in medicine. I mean, it saved millions of lives, and antibiotics save countless lives even today. But again, we have this sort of Pharmageddon where the pendulum is swinging the other way and we're seeing overuse of these antibiotics. So I'll tell you, in my practice, it was very apparent to me 15, 16, 17 years ago, before we had this plethora of scientific studies, it was very apparent to me as a gastroenterologist who treats a lot of inflammatory bowel disease, Crohn's, ulcerative colitis. As I said, autoimmune GI diseases is my jam. It's my area of expertise, where I trained at Mount Sinai. Dr. Burl B. Crohn and his colleagues, Drs. Ginsburg and Oppenheimer, described Crohn's disease in the early 1930s. And it was, you know, I tell people that I went to medical school, did my internship residency and a year as chief resident at Columbia, just uptown in New York. And my first day of my GI fellowship at Mount Sinai, I saw more IBD in that first day than I'd seen in 8 years at Columbia. Now, Columbia's still a fantastic institution, don't get me wrong, but the diseases that we were seeing, we had the Heart Failure Center at Columbia. It was, we had incredible cardiology, we had liver transplant, we had other things going on, but Mount Sinai at that time had the reputation, and still does, quite frankly, as a hospital for inflammatory bowel disease. And they had the GI Care Center. It was just floors and floors of patients with Crohn's and ulcerative colitis. So you really, in the GI clinic there, the vast majority of patients I saw at Mount Sinai had IBD, as opposed to Columbia, where I was seeing some IBD, but a wide range of other things. So as somebody who loves taking care of patients with autoimmune disease, it was very apparent to me in my practice over a decade ago that there was often this compelling history of antibiotic use. I remember a young woman I saw who was recently diagnosed with Crohn's, and I would always delve into the antibiotic history and actually had to call up her mom. And her mom said, yes, she had something called posterior urethral valves when she was a young child, 3 or 4. And these posterior urethral valves were causing the urine to reflux back up her urethra into her bladder and causing frequent bladder infections. And her mother told me, she did eventually have surgery for this problem, but before she had surgery, she was on suppressive antibiotics for 3 years straight. Well, what does that mean? It means antibiotics, just put on antibiotics to prevent infection. Now we know that that leads to terrible things, right? A 3-year-old, 4-year-old whose microbiome is still developing, 3 years of antibiotics straight is going to be hugely disruptive. This is a woman in her 20s. At the time, that wasn't on people's radar. People weren't really aware of that. But I'm seeing risk factors like that all the time. And my own daughter, who many of you have heard me tell the tale of antibiotics I got at birth, not my birth, her birth, during the delivery, because I had a cold, a flu, viral infection, but one of those, just in case. And then antibiotics she got at birth because of my fever, in the NICU, potent IV antibiotics, and 20 courses of antibiotics before she was 2, and being such a sickly child, etc. That was really the conduit for me to become really interested in the connection between the microbiome and health and disease. But I bring her up because I remember she was struggling with frequent ear infections, pharyngitis, etc. We went to see this really wonderful pediatric allergist and immunologist, and I'm not going to say her name, but I want to say, first of all, that this woman is a fantastic doctor, and she was very well-meaning, very earnest, and very interested in Sydney getting better. Unfortunately, she was not well informed about the connection between long-term antibiotics and illness, as many of us were not, 15 years ago. And Sydney had fluid in her ears that wasn't going away after multiple ear infections, which, we know now many of those ear infections are viral, but they were being treated with antibiotics at the time. And the pediatric allergist and immunologist said, okay, fine, we're just going to put her on suppressive antibiotics. And so I was, by this point, I was like, okay, I'm thinking this road we're going down is not a good road. And I said, well, what does that mean? And she said, well, we're just going to put her on the antibiotics until the fluid clears up. And I said, well, how long is that? And she said, indefinitely. And again, I had not had my aha moment. I didn't know all the stuff I know now. But even so, it struck me as, this is not a good idea. My wheels were turning because I was thinking about all the patients I was seeing in my medical practice who had that same history, who were on boatloads of antibiotics in childhood and now had developed autoimmune disease. So I was putting 2 and 2 together and saying, yeah, I don't think this is a good idea. I mean, maybe this is helpful for the air situation, but this is going to cause a problem down the road. And this is so typical of what we do in medicine. We whack a problem with something, and then some other problem pops up here, and we whack that problem, and pretty soon, we have multiple pharmaceutical hammers whacking away at different problems, and a lot of the problems we're treating are really the side effects and the sort of fallout of, whatever hammer we're using to solve the problem. So again, I don't blame her. I don't fault her. She's someone I hold in high regard. I think she just wasn't well informed. The tide was turning, and it's turning for all of us. I've prescribed a ton of antibiotics in my practice over the years when I was poorly informed. So one of the things I want you to do, I really want you to do this for me, it's so important, is I want you to educate not just your friends and family, your colleagues, but your doctors. And I want you to do it in a nice way. I don't want you to say like, you dumbass, don't you know? Haven't you read the study in gut about antibiotics and IBD? Don't do that. Be nice the way my patients were nice and were like, actually, I've been hearing about such and such, and there's a study, and so I really prefer to avoid the antibiotics if at all possible. And again, go back to my second book, The Microbiome Solution. It's somewhere up on the shelf above me. And look at that list. It's also in the antiviral gut. 10 questions to ask your doctor if you've been prescribed an antibiotic, starting with, is this antibiotic really necessary? And then going down, alternatives, narrow spectrum, etc. Another really exciting study recently showing that shorter courses of antibiotics are actually better when possible. We've always said, you need to take antibiotics for the full 10 days. It turns out there's a whole movement now in infectious diseases to limit stuff. For urinary tract infections, sometimes that's just 3 days. And even for pneumonias and so on, sometimes it's 5 days instead of 10. And we're now realizing that shorter is better. And of course it is, because the less time you're on the antibiotics, the less disruption of the microbiome you're getting, right? So that's for another day. So I want you to do that for me. I want you to recognize that healthcare, good healthcare, is a dialogue. It's not a monologue. Today's a little bit of a monologue, although I'm going to be taking your question shortly, right? I'm just sort of talking at you. But, so much of what I know and have learned that is really useful, and that's why I feel such an obligation to sort of spread the word and pay it forward, I learned because of the generosity of so many of my incredible patients. Hopefully some of you are on this call today, right? Who, it wasn't necessarily them telling me about an article. I mean, I feel like I'm pretty well read, but it was them sharing their experience with me and saying, I was on doxycycline for acne as a teenager. And then, a year after I'd been on that doxycycline, I started to develop bloody diarrhea, and lo and behold, I had ulcerative colitis. So sharing that and really, rolling up our sleeves together and being medical detectives and saying like, I wonder what the connection is between this and this. And, sometimes calling up parents or grandparents and like, do you remember when she was this age, what happened, and all of that, right? So it's really kind of sleuthing, medical sleuthing, to see if we can find those connections. And it's great now we have large studies. I mean, look at this study, 6 million people. We have meta-analysis where they pool multiple studies so that we're able to scientifically validate what many of us have observed. And I'm not just talking about healthcare practitioners, patients. The patients are often like, oh yeah, there's no question this was related to that. And while we're on antibiotics, I just want to mention NSAIDs, non-steroidal anti-inflammatory drugs. I had a patient and her mom, this has got to be 23, 24 years ago, shortly after I came to Georgetown. Young woman, and she was a little wacky, I'll say, right? But you get a little wacky when you keep saying to doctors, this is what's going on, and the doctors are like, yeah, right. When you are not believed, it makes you a little crazy because you start to doubt yourself and you get paranoid. So this young woman, she was in her early 20s. There was also a little murkiness around it because she had had an accident in another city where she had fallen. It was like a manhole cover or something, and she had a very bad accident in a public area, and there was a lawsuit going on. So that increased the murkiness. She was suing the city, and it was a big lawsuit. And as a result of the accident, she had taken a lot of non-steroidal anti-inflammatory drugs, a lot of ibuprofen, Motrin, Advil, Aleve, Anacin, etc. And shortly after this sort of mega high dose non-steroidal use, she had developed ulcerative colitis. And she was convinced there was a connection. And at the time, I mean, this is more than 20 years ago, we just didn't have that connection. Now we know that an increase in intestinal permeability is associated with inflammatory bowel disease. And what do these drugs do? They increase intestinal permeability. So again, let me be clear. I'm not drawing a straight line between non-steroidal anti-inflammatory drugs and inflammatory bowel disease. But what I'm saying is that these environmental triggers, many of which are pharmaceutical, in somebody who, perfect storm of genetic predisposition, dietary factors, everything, all the other things I talked about, can be one of those environmental triggers, right? So, I have to say, if she's out there listening, at the time, this was, 22, 23, maybe even 24 years ago. I joined the faculty at Georgetown in 97, and this was, maybe 98. At the time, I was a little like, I'm not sure that the NSAIDs caused it. And again, there was a lot of murkiness around the lawsuit, etc. But I feel like I sort of gave her short shrift, to be honest. And that was because, again, it wasn't because I was well-meaning. I was poorly informed. So if she's out there, I hope your ulcerative colitis is better. And I thank you for, the education that you provided by way of sharing some of those details, right? And I'm sorry that I wasn't sufficiently informed. I mean, I think the world wasn't sufficiently informed. So it's so important for you as well-informed consumers, as people who pay attention to your health, because you're joining me Tuesday at noon, so clearly you're interested in your health, to pay attention, to try and make these connections and to share them with your healthcare professionals. Now, sometimes the connections aren't correct, right? And I'll give you an example. I'm very allergic to peaches. I've gone into anaphylactic shock from peaches before. And one day, many years ago, 20 years ago, I ate some strawberries at my sister's and I had hives, like lip swelling, all of this. I was like, oh my goodness, now I'm allergic to strawberries. And I avoided strawberries assiduously. And then one day I was eating strawberry jam and my sister was like, hey, you're eating strawberry jam and you're fine. Are you sure you're allergic to strawberries? It turned out that the strawberries had been in a bowl with peaches and had the peach fuzz on them. And I wasn't allergic to strawberries, but you couldn't have told me that that wasn't the case, right? I had made this association. There was no unconvincing me. So we're not always correct with our associations, but we always deserve to be listened to and to have these things considered, because you are the best person to, you're in charge of your body. Like, you're living in it every day, all day. You're noticing these things. The doctor's just getting a snapshot. Okay. So I want you to share this stuff, to share what you know, what you're feeling, etc., with your physician, so that we can all educate each other and all be healthier together. All right. Enough of the soapbox. Let me take some questions from you guys. All right. And I'm not going to go backwards this time. I'm going to go from the top. Okay. From the top. Okay. So there's a question, just says Candida or Candida. Some people pronounce it. I don't know that there's a right or wrong way. I say Candida. Candida is a fungal organism, a type of yeast, and fungal organisms are a normal and important part of our microbiome, right? When we talk about microbiome, we're not just talking about bacteria, we're talking about fungal organisms, viruses, parasites, protozoa, which are little one-cell organisms, archaea, all of it. Fungal organisms in our gut play an important role in digestion, but we don't want too many of them. So when you take an antibiotic, kills off a lot of the healthy bacteria. Now the yeast say, oh wow, look at all the space, we're gonna multiply. And you get fungal overgrowth. It's not an infection because it was in your gut or your vagina to begin with, but now it's overgrown, or in your mouth. So you can get thrush, oral candida in your mouth, coating your tongue after antibiotics. You haven't caught it from anybody. It's been in there, but now it's overrepresented. The problem is usually not the candida. It's not the overgrowth of candida. It's an underrepresentation of the healthy bacteria. So I see a lot of patients who go on a scorched earth mission to destroy every fungal organism with potent antifungals, which can be tough on the liver. But what we really need to be doing is we need to be repopulating with those missing organisms, and then the candida will come back down to normal healthy levels. Okay. What else we got? Hello from Northern California, Bloomer Girl. Nice to see you. Okay. Where are the questions? Look at all you fantastic people who have joined me. I'm sure there's some questions here, though. Let me get to them. And maybe there's a good way to find these, but I'm not good at it. All right, I'm sure I'll find some soon. Hang on. Okay. What about antibiotics for strep throat? This is from Tina. Hi, Tina. Such a good question. Let me say again, I am not your doctor. I'm not telling you how to treat your strep throat, but let me tell you why we treat strep throat. Strep throat is caused by a bacteria. I mean, assuming you've had a culture and it is strep. It's pharyngitis. It's inflammation, infection of the pharynx, and it can be caused by a number of organisms, but let's say it's caused by Streptococcus. We treat strep throat to avoid two very serious, but very rare complications. One is called post-strep glomerulonephritis, and that's a kind of kidney disease. The nephrons are the cells in the kidney. And the other is rheumatic heart disease. Very rare diseases, but we saw them pre-antibiotics 100 years ago. After strep, people could get post-strep glomerulonephritis, rheumatic heart disease. Very, very rare. What I'll tell you is that the risk of antibiotics these days causing antibiotic-associated diarrhea, Clostridium difficile, autoimmune disease, decreases in cognition, etc., is pretty high. And strep on its own in somebody who's relatively healthy will resolve on its own in the vast majority of cases. The antibiotics will reduce the illness, the duration of illness, and they will decrease the symptoms. But it is very unusual, let's just say, for somebody to become mortally ill from strep, except if you have an abscess. If you have a pharyngeal abscess or a peritonsillar abscess, you will need antibiotics. But run-of-the-mill strep throat will run its course, and the vast majority of people will last a couple days longer. Symptoms may be a little bit severe without antibiotics. So therefore, that decision about whether to use an antibiotic or not has to be a very personal decision. It can't just be based on what's going on today. It has to look at the big picture. It has to look at your genetic history, your family history of diseases, your diet, your lifestyle, other antibiotics you've taken. You have to take it all into account so that you can do a full reckoning, a risk-benefit reckoning, and decide whether that strep throat really needs to be treated with antibiotics or not, right? And let your doctor help you with this decision making. But it's not just a reflex, oh, I've got pharyngitis, here's an antibiotic. Because if you do that every time you're sick, that's gonna add up. And you may not be looking at other factors like what can I do with my diet and other things, right? So that's the answer about antibiotics for strep throat. It's not necessarily an automatic. It depends on a lot of other things, including your severity of symptoms, your past history, etc. And definitely have a conversation with your healthcare provider about that. All right, what else do we have? Okay, from Tina, doctors give antibiotics for strep throat automatically. Do you agree with that? I think I just answered that question. Some kids get it once a year. Yeah, and so, the statistic, Tina, is that the average American kid has had 18 or more courses of antibiotics before their 18th birthday. And so, in light of this Danish study, 5 or more courses of antibiotics increase risk of inflammatory bowel disease. We know from the Nurses' Health study in middle-aged women, more than 2 months of antibiotics over a several-year period, significant decrease in cognition, equivalent to aging your brain 3 or 4 years. And then you combine that with the ultra-processed food and everything else. So none of these things should be automatic. All of them should involve a very detailed conversation with your healthcare provider about risks and benefits. All right. And I think you guys are all convinced. I'm preaching to the choir here for sure. All right, what else do we have? Your questions are always so good. Is that my amazing daughter, Sydney Mann, who's on this call? Hi, Sid. I can't believe you joined me for office hours. You want to spy on me and see what I'm telling everybody about you? What I want to tell everybody about you is that you are the most amazing, glorious 17-year-old I've ever met in my life. You are the stronger, fitter, faster, cuter, funnier, more sarcastic version 2.0, and I'm so proud of you every day. I hope you're not cutting class. Okay. Park City Julie, thanks for being on. Oh, it's my pleasure to share this information. Okay, can I explain the difference between IBS and IBD? Absolutely. And before I get to that, yeah, Tina, doctors think you're crazy if you question antibiotics and strep. Well, they're crazy for not questioning it, right? We know that. Jocelyn says, my kid's pediatrician says it does not go away on its own. She insists they need antibiotics. Okay, Jocelyn, I want you to Google, strep without antibiotics, find the studies, show them to her, because again, I doubt that she is just like a terrible doctor, right? She probably doesn't know. Like we were taught in medical school, however many years ago, for me, that was 31 years ago, that this is what you do. And, she may not be up to date. So I want you to have a little bit of a conversation. Okay. Is there hope after being on long-term and strong antibiotics for diverticulitis and kidney infections? There absolutely is. And a little bit of shameless self-promotion. My second book, The Microbiome Solution, gives you a whole protocol for things that you can do. All right, let me not forget that question, IBD versus IBS. IBD and IBS are completely different disorders. They unfortunately have acronyms that sound kind of similar, but irritable bowel syndrome, which is a whole other kettle of fish because I like to call it lazy gastroenterologist syndrome. It means that somebody didn't roll up their sleeves and figure out what exactly is making your bowel irritable. But that can be constipation predominant, diarrhea predominant, alternating, bloating, abdominal pain, etc. But by definition, if you have irritable bowel syndrome and I do a colonoscopy on you or an upper endoscopy, your gut looks normal, okay? You don't have diverticulosis, you don't have Crohn's, you don't have colitis, you don't have celiac disease, etc. So it is still a diagnosis of exclusion. And if I slice up the IBS pie, I see all kinds of interesting things like gluten intolerance, lactose intolerance, undiagnosed parasites, undiagnosed celiac disease, diverticulosis. So a lot of people who are put into that IBS pile actually have other things that are causing their symptoms. Irritable bowel syndrome means we looked and we don't see anything. And we know the hallmark for irritable bowel syndrome is this sort of visceral hypersensitivity. If I pump your rectum up full of air, you feel uncomfortable at a lower level of distension than someone else. That's sort of the classic IBS. But we know a lot of people with IBS have disruption in their microbiome. They don't have an autoimmune disease, but they still have dysbiosis, a disrupted microbiome, in many, not all. Inflammatory bowel disease refers to two diseases: Crohn's disease, the one I told you was described by Dr. Crohn, Dr. Oppenheimer, Dr. Ginsburg in the 1930s, and ulcerative colitis. And those are two autoimmune gut diseases. Inflammatory bowel disease, IBD, versus irritable bowel syndrome, IBS. So beyond the names being different, what else is different about these diseases? Well, inflammatory bowel diseases, Crohn's and ulcerative colitis. Crohn's can involve any part of your GI tract from the mouth to the anus. The most common area of involvement is the ileum, the end of the small intestine called the terminal ileum. That's the most common area to be involved. And Crohn's involves a full thickness of the bowel wall. So not just a mucosa lining, but the serosa, the subserosa, all the full thickness. And it can cause strictures, it can cause fistula, it can cause inflammation. Ulcerative colitis just affects the colon, not the small intestine, and it involves just the surface lining, just a mucosa lining. That can also cause ulceration, bleeding, inflammation, strictures, and there's a lot of overlap with the treatment for Crohn's and ulcerative colitis, and some people have indeterminate colitis where they have some features of Crohn's, some features of ulcerative colitis. So we don't make as big a deal as we used to about deciding it's Crohn's versus ulcerative colitis, right? We just want to figure out how to get people better. And one of the things I do in my medical practice is I help people with inflammatory bowel disease get their disease into remission without immunosuppressive drugs like steroids or biologics. Why? Not because these drugs aren't effective, they are, but because the side effect profile for cancer, infection, etc. is really problematic. And I had closed my practice to new patients for the last year, but I'm so excited. I'm reopening in about a month, and so excited to be seeing patients again in person. I'm renovating my office, so looking forward to it. It is really gratifying work helping people with autoimmune disease get their disease into remission, and particularly when we're able to do it with diet and less toxic medications. All right, so what else do we have question-wise? Okay, how to treat SIBO, small intestinal bacterial overgrowth, and yeast overgrowth in the gut at the same time. So yeast overgrowth can be part of the bacterial imbalance, right? I don't love the term SIBO, small intestinal bacterial overgrowth. And in fact, it was sort of promoted by a drug company, the drug company that sells Xifaxan, because they want you to think that you have overgrowth of bacteria and therefore you need an antibiotic, where really what you have is an imbalanced microbiome. You have too much of some species, not enough of the other. And you sometimes do have more migration of bacteria into the small intestine. The small intestine is not sterile, but it should typically have a lot less bacteria than the colon. And what we see is that certain drugs, including antibiotics, including acid blockers, can create that disruption. by removing the acid in the higher part of the GI tract, they encourage more overgrowth. So we know that those drugs are common precipitators of these conditions. I do not use Xifaxan in my practice because I find that it is short-lived. It kind of sterilizes the gut. It removes a lot of bacteria. You feel better for a few weeks, and then the symptoms tend to come back even worse. And similarly, an antifungal isn't usually the mainstay of treatment. The mainstay of treatment is to figure out how to repopulate your gut and get it into a more balanced state. So, when you really think about it, you can't treat something caused by antibiotics with more antibiotics and expect that you're going to get a good lasting result, right? Okay. And I have a lot of resources for SIBO. If you go to the website, gutbliss.com or robinchutkan.com, ROBYNNECHUTKAN.com, and look under SIBO. You'll find good resources, a good free gut guide to SIBO. And as I said, the second book, The Microbiome Solution, is really all about that. Okay. What else do we have? How do we treat intestinal parasites? So the first thing that we need to do is we need to make sure the parasite is actually responsible for your symptoms, because just as we have lots of, bacteria and viruses in our body, we have parasites in our body also that are part of our normal ecosystem that aren't necessarily causing the problem. And one of the things that, I talked about my patients from the State Department or the Peace Corps being overtreated for these self-limited gut-related infections and then the antibiotics causing the problem. I see the same thing with parasites. So for example, there are a number of sort of, self-limited parasites or parasites that we don't even think of as being pathogenic. So if we look at entamoeba, amoebiasis, entamoeba histolytica, we definitely need to treat. But entamoeba hartmannii, we don't. That is considered a commensal. And so it's not like, I have a parasite, let's treat it. And you could have a parasite that's just there hanging out, and your symptoms could be related to something else. And a lot of the antiparasitic agents also are antibacterial. They're going to disrupt the gut microbiome. So it's really important to be seeing somebody who has experience with parasitic diseases, who can tell you, yes, this parasite that we're seeing is actually responsible for these symptoms and is worth treating, and here's how I'd recommend treating it, versus just, test on the internet, I have a parasite, I'm going to treat it. And again, drawing that straight line. So to answer your question, how do we treat intestinal parasites? It depends on the parasite, depends on the symptoms. What are my thoughts about using citruses for fiber supplement? Do you mean Citracel, maybe, Elizabeth? If you're talking about citrus, like eating citrus for fiber, sure. Make sure you're eating the whole fruit, like not orange juice, right? But the whole orange for fiber, that can help increase fiber consumption. But I think this is autocorrect typo, and I think you mean Citracel, Citrucel. And yes, Citracel is a very reasonable form of fiber supplement. I like psyllium husk, Psyllium, for constipation and diverticulosis, but not everybody tolerates it as well. So Citracel brand is fine. I use acacia fiber. It's less viscous than psyllium, so it dissolves a lot easier. It depends a little bit on what we're trying to treat. Dr. Jillian Ross. Oh my goodness. I am so thrilled to see you. I got to just brag about you. Dr. Jillian Ross, who's an internal medicine resident at Georgetown, contacted me years ago when she was a medical student at Howard University. And she contacted me. She wrote the most beautiful email and said, I want to do an internship with you in your office. And at the time, I didn't have any people doing internships with me in my office. But rather than just sending her an email back saying, can't help you, I said, this is such a beautifully written email. I'm gonna meet her. And I met her and I was so impressed with her. I was like, yeah, I don't have an internship, but I'll create one for you. And she worked with me for a summer. She did all kinds of things. She worked on a research project. She helped with patients. She shadowed me at the hospital for endoscopy. And even some of my surly colleagues were so thrilled with her. And then she applied for residency. She got interviews basically everywhere. Like when people were getting 1 or 2 interviews, she was getting 20. And I remember calling the residency director, Jillian, I just have to embarrass you, at Georgetown, Dr. Shawn Welton, when she was applying, to say, hey, she's really spectacular. And he was like, yeah, no need to call me. She's already at the top of our list. And so she is an internal medicine resident at Georgetown, kicking ass, and is just, such an all-round amazing person. So Jillian, thank you for joining me. I'm so proud of you all the time. All right. Somebody wants to know, Laura Finkelstein, do I see people out of state via telehealth? I do. And if you check back on the website in about 3 weeks, we'll have all the information there for how to become a patient. And I do hope to see you. Okay. Yes. So that, Elizabeth, was Citracel. Thank you for clarifying that. From Kim, can autoimmune diseases go into remission if carefully treated? Yes, 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 Kim. All the time. This is literally the thing that brings me so much joy in my practice, is helping people get their autoimmune disease into remission without harmful drugs that could potentially kill them, right? Now, to be clear, sometimes you need those drugs. Sometimes you need immunosuppressive drugs, biologics, because the autoimmune disease is just so active and you need to get it to a more moderate level. Some people need to stay on those drugs long term, but many people could use a drug to get it to a more moderate level, from severe to moderate, and then use, dietary intervention, some well-chosen probiotics, etc., to get into remission. And I want to say remission isn't just about diet or probiotics or even a fecal transplant. Remission is also about sleep, about stress, about alcohol intake, about, exposure to nature. All of those things go into the equation for how to get these diseases under control, right? I just want to give a shout out and mention to my colleague, Dr. Terry Wahls, Wahls. Terry is a physician and herself has MS, multiple sclerosis, wrote a fantastic book called The Wahls Protocol, Wahls. It's one of those on the shelf behind me. We have the same publishing team at Avery at Penguin Random House. So shout out to Lucia and everybody at Avery. And I was introduced to Terry actually at a conference almost 10 years ago. My book, Uplift, had come out. Her book, Wahls Protocol, had come out. And let me tell you, she's a real deal. She is helping people, she calls them Wahls warriors, get their MS into remission. And again, she's not just a physician who treats MS. She herself went from being wheelchair bound to now riding her bicycle, etc. Follow her on Instagram. She is fantastic. So yes, I help patients with Crohn's and colitis get their autoimmune disease into remission. In my medical practice, we have about an 80%, 79 to 80% success rate without biologics and steroids. Terry, same thing, great results. And there are lots of other people out there. There's a woman who I also met at a conference. I think I met her at the Plantrician Conference in California 6 or 7 years ago, named Brooke Goldner. Her practice, if you will, is called Goodbye Lupus. And she herself had lupus as a young person, I think as a medical student, was in kidney failure. And she has conquered that with plant-based diet and some other things. So Brooke Goldner, I think she's a psychiatrist by training. So there are a few of us out there in the world really trying to help people get their disease into remission. And again, it's not that I don't like these drugs. It's that these drugs have potentially really problematic side effects. So if you can try a diet and lifestyle approach first and that works, why wouldn't you, right? Sometimes it doesn't work and you need to climb up the pyramid. But I always recommend a bottom-up approach rather than a top-down approach where we're starting with the most aggressive medication, because those aggressive medications that have high efficacy also tend to have high side effects. Okay. For someone who had chronic cough, treated H. pylori with aggressive antibiotics, anything in gut change that would cause the cough? That's so interesting. I don't know. Without, Rose, it's really hard to know without knowing a little bit more about your medical history, but it sounds like you made that careful observation that you had the aggressive antibiotics for H. pylori and then developed the cough, and that there's a connection. So, hard for me to just throw out an answer without knowing more, but I would keep investigating if you think there's a clear connection there. And I'm glad that cancer has been ruled out. That looks fantastic. That's great news. Okay, so you know what? We are at the top of the hour, so I'm gonna cut it short here. But I want to tell you all about something free that I'm offering, and it's the Antiviral Gut Masterclass. And most of you know my new book, The Antiviral Gut, came out on November 1st. And as part of the pre-promotion efforts before the launch, I created an Antiviral Gut Masterclass, and it's free, and you just have to show proof of purchase to sign up. And let me just tell you a little secret. I don't care whether you bought the book or not. I hope you bought the book because it's a really good book. But if you didn't buy the book, just take a picture of it and submit that. So when you go to robinchutkan.com and the Antiviral Gut and the book page, or you can find it under courses, and you'll see the Antiviral Gut Masterclass. You have to upload a PDF or JPEG, some receipt for the book. Don't tell my publishers this, but I don't care if you bought the book. If you upload something, picture the book, you can sign up. It's February 7th. I have the most fantastic lineup of medical colleagues. I have Dr. Ida Bergstrom, who's a fantastic internist locally. I have Dr. Gail Balba, an infectious disease expert. She's going to talk about Mpox, SARS-CoV-2, all kinds of things. I have Dr. Rob Marshall, a cardiologist, who's going to talk about myocarditis and the heart and viral illnesses. I have, who else do I have? I have Dr. Winnie Han, a radiologist, who's going to help you figure out whether you need to get an x-ray if you have a viral illness and respiratory symptoms, difference between x-ray, CAT scan, etc. I have Light Watkins, who's a meditation expert. I have Matteo Pistona, who's going to talk about breath work. I have Elise Muselis, who did all the amazing recipes in the Antiviral Gut, and a bunch more. I have Dr. Claudius de Simone, who developed one of the most potent probiotic formulas. So I really just kind of sat down and I said, okay, who's my dream team of practitioners who have great information that I want to share with people about how to have an antiviral gut and, about acute viral infections, post-viral syndromes, etc. And I am so thrilled to make this available to everybody free. So do sign up. Again, robinchutkan.com, ROBYNNECHUTKAN.com. Go to courses. You'll see the Antiviral Gut Masterclass, free, and I don't do anything with your email information. I can barely use your email information to email you something like this, much less. There's no selling, there's no advertising, nothing. But it is going to be a great course. If you can't join us live on February 7th, then, it is going to be archived. But to get access to the archive version, you got to sign up. And it's going to be like 3 hours. It's like 7 to 10 p.m. It's going to be fantastic. It's going to be live. I've pre-taped a lot of the interviews, but I'm also going to have people live to answer questions. So I'm super excited to provide you, with this great information. It's really one of my passions as a physician, is providing you with really great, clinically validated, scientific, non-commercial information. I'm not trying to sell you a supplement or, a green powder, any other stuff. I'm just trying to provide you with really good advice. And I hope in return you will think about buying my book, if not this one, The Antiviral Gut, then The Microbiome Solution, or one of the others. And I'll see you next week. Bye, everyone.